Thank you very much. I'm going to, give you guys a lot of feedback. Try not to. Does that sound better?
Yeah,
Okay.
Just the volume too. So.
Okay. And talk about advances in radiation therapy. And I know it's kind of a broad audience, so I wanted to cover kind of the basics of how radiation works for everybody, especially this is not something that usually a lot of hematology oncology people have exposure to. So I have no disclosures. And everybody always comes with some misconceptions about what radiation can do or what radiation oncologists can do. And this is just some of the, attributes of radiation in pop culture that we have. And basically today I'm going to cover some of the basic radiation techniques for prostate cancer and how it's evolved over the last 20 years. And also learn new options because of our evolution of how we deliver the radiation, how we've gotten better and we can actually deliver treatment in a shorter time course. And then how we're also using radiation, whereas 10, 15 years ago, there was a vigorous debate about should patients have surgery, should patients have radiation, what should you do? And now we're actually finding, we should be doing both. And basically, the principles behind radiation are that it alters the DNA. Radiation's on the spectrum of energy from light through microwaves up to higher energies, up to X-rays, and then for what we call radiation, gamma rays are a specific energy of radiation that comes from cobalt, and then linear accelerators actually use energies that are even higher than that. And basically the radiation damages the DNA and doesn't kill the cells directly, but kills the cell's ability to reproduce. And with radiation, our goal of the radiation is to try to get the radiation only on the tumor and trying not to get it to anywhere else, but that's not always physically possible. So what we do is we try to minimize the amount of radiation that we have to adjacent tissues and surrounding tissues around. And the technologies that we use for that are everything from daily CT imaging. We have a separate technology called Calypso, and we also can do intraoperative radiation. So here's a picture of a normal linear accelerator, a modern accelerator. And basically, looking through the audience, I think everybody here knows what a CRT TV, our old TVs were before we had all the flat panels. I know in my career at some point I'm going to be giving a talk and people are going to have no idea what I'm talking about. But if you remember your old TVs, we had to have a big depth of it because mainly there was an electron gun that generated electrons and it shot out and hit a phosphorus screen to generate the light. And so you needed that distance, and it's more narrow in the back than it is towards the front. And that's because that's the direction the gun shot out. And that's basically the same principle of our linear accelerator. This is an electron gun, except this is about 3 orders of magnitude more power than your TV. And the electrons get shot out down this length, and then they get bent around and hit a target up here, and they generate X-rays. So instead of generating light, we generate X-rays. That's the basic principle of a linear accelerator. And in the past, when I started training, actually, what we used to do was just take X-rays, and we would draw what we call a large pelvic field to ensure that we covered all the pelvic lymph nodes and the prostate. But you had no idea where the prostate was, but you kind of guessed, and so you would draw a little red line and make yourself feel like, okay, that's where the prostate sits. And then we would actually focus our beam down after about halfway through the course, and we would use the CT scan to at least do this, but we'd still have margins of almost 2 centimeters on where the prostate sat. And you can see that this is a pretty crude technique for treating, basically a full large pelvis of a patient. And then during this time, we also developed prostate brachytherapy, and this was a neat way of getting the radiation directly to the prostate. You put hundreds of radioactive seeds directly into the prostate, and the radiation stays confined to that area. These days, our shaping of the beam is accomplished with what we call a multi-leaf collimator. And this picture gives you the idea of the depth of how thick these leaves have to be. But these leaves are actually 2.5 millimeters thick, and they can slide in and out and shape the radiation. And I've got a little video that kind of demonstrates how that works. But essentially what we do is we aim multiple beams from all different angles so that there's a low amount of radiation that basically bathes the body, but where they all meet in the middle, where they all coincide, is your hottest spot of radiation, and that's where the maximal effect of the radiation is going to be. And when we do our treatment planning these days, we basically use a CT, bring the information in, and recreate the patient's body in 3 dimensions on our CT scanners. And one of the biggest developments that you've probably heard of is intensity modulated radiation therapy. And essentially, basic radiation, if you think about it, is like large beams of light coming from like a spotlight, and you can aim multiple beams. But what we do with intensity modulated radiation is suddenly you take each one of these large beams and you break it into hundreds of pencil beams. So the analogy is like instead of you having a fire hose or a large faucet where your water's coming out, suddenly you have the ability to control each one of those little nozzles, kind of like your a super what do you call it, water pick, shower head. And if you control each one of those little beams, you can suddenly do things that you couldn't picture before. And that enables us to target the radiation where we want to go. So here's a picture of our latest linear accelerators coming in. And basically the beam still comes out the linear accelerator head from here, but we also have 2 arms on the side. And these enable us to take x-rays and do a CT scan on the treatment table in treatment position every day. So this video playing actually shows you kind of how the multi-leaf collimators can move. And I'm only going to play this for about 30 seconds, but basically just shows you how quickly these MLCs, what we call the multi-leaf collimators, will move during a treatment and delivery of the radiation. So these days the machine actually, instead of using even static beams, when it treats, it actually rotates around the patient in 360 degrees, and while it's rotating, it's constantly delivering a small amount of radiation each time through all those different angles. So we can really focus the radiation on just one spot while keeping the doses to the rest of the body extremely low. So I'm going to skip the video now if I can. And this is a modern IMRT treatment plan. And this is the CT scan that shows you the different planar slices through the body and how the dose is distributed. So this is an axial CT scan, which you typically see when you just look at a normal CT. And this is an isodose line, basically areas that are red are the hottest areas and the areas that are green are cooler areas of radiation. And you can picture this diagram up here shows all the beams coming in from different angles. This shows you in the coronal distribution how the radiation is shaped to the prostate, and this one shows you how we're shaping the radiation, actually directly bending it around the rectum right here as well. And that's how we deliver the radiation these days, and it's translated to dramatically lower side effects. This shows you kind of the same principle for a lung tumor where we aim multiple beams, and they're all coincident on the tumor at that location. Sorry, duplicate slide there. And so the ability to focus the radiation has enabled us to do things that we couldn't do in the past, stuff that we were limited by toxicity. So basically with our ability to now reduce the margins that we need to treat, we can actually increase the radiation dose to the target. And the question is, does giving more radiation actually help kill more tumors? Sounds kind of simple, but we actually had to prove that in randomized trials. And this is data from MD Anderson that shows survival curves for 78 gray up here for biochemical control versus 70 gray down here. And the same data in a non-retrospective fashion from Memorial Sloan Kettering. So any discussion about radiation really has to include proton therapy, and you guys probably have heard advertisements or news about protons. Currently, there are 14 proton therapy centers in operation, another 10 under construction, and another 21 being investigated. And basically, what is protons? Protons is still external beam radiation. It's still aiming the beam from outside at the target. The main advantage of protons is when you shoot a normal radiation beam, just like you shine a flashlight into water or into the ocean or something, you're going to see light further down, much further. It just keeps going, but it gets attenuated as it goes down. So, if you're underwater in the ocean and you see the sun, it's not as bright as it is as when you're at the surface. Protons, basically, if this is a single energy proton beam, and this is the depth in water, so basically you're shining it into the water, and if you had a normal X-ray, you would see it just kind of decline over time. A proton beam goes into the water, And then as it slows down, it has this crazy phenomenon where it deposits its energy to the third, and it slows down even more. So suddenly it hits this point, what we call a Bragg peak, and it just stops right there on a dime, hopefully. And essentially, this could be theoretically advantageous if you could control it, where you could aim it in one direction and stop it before it actually hit the a organ that you don't want to treat. But this peak is actually unpredictable in reality, so we can't use this peak. So what we do is, with protons, you summate multiple energies of protons, and you get what we call a spread out Bragg peak, superimposing multiple beam energies. And then you don't get the exact same stopping distance on the backside here, but you at least get a much more usable, much more homogeneous beam that you can control. Still with the advantage that it doesn't exit. And this shows you kind of an X-ray photon beam in the same kind of depth dose curve, how it just keeps going as you go on. And here's the schematic for a proton center. This is why they're so difficult to build. You don't just stick one in a department. It requires a separate building. This is a synchrotron, and this thing is a particle accelerator, much like they have in CERN, but on a smaller scale. But still huge. And it cycles the particles, and they get shot out, and they get shot out into each individual treatment room. And this is the size of the gantry for one of these proton centers. A gantry is basically the treatment beam, treatment nozzle that we have. And so the nozzle part's here, and this actually shows you the scale of the patient under this gantry. This thing is huge. And here's with a school bus, just to show you kind of the perspective as well. This is why they're so expensive and why it's so controversial. Here's what it actually looks like in the treatment room, so it's not so intimidating. You're not being treated by the Death Star. But the gantry actually rotates underneath the floor of the room, and you don't even see the whole thing. It's actually, out another 20 feet beyond here. So here's how a proton, oops, did I do that? Here's how a proton beam can treat versus X-rays. So for a target here, this one shows a very crude a 2D plan, but basically we're treating with two beams, and the beam keeps going. With a proton beam, theoretically, you could stop it before it hit the vertebral body and hit the spinal cord, and you would just get the target there. So that's the theoretical promise of protons. The unfortunate reality is right now, because that gantry is so big and it's hard to modulate the beam as well as you can with external beams, with protons, rather than doing multiple beams all around, they're treating with only two beams. So for prostate cancer, it's only two beams. So you see the world in two dimensions, which it definitely doesn't have as much depth or as perspective and the ability to shape the radiation in two dimensions as it does in three dimensions. And so basically the pros of protons are it's still external beam, there's no exit dose, less total energy around the body. The cons are you have limited beam shaping, and then what they don't tell you is that because of that spread out Bragg peak, the stopping distance right now is about 11 millimeters, the uncertainty around the stopping distance, anywhere between 7 and 11 millimeters, which is a lot larger than what we can do with IMRT right now, where our margin's around 4 millimeters. There's no beam modulation, and there's limited access, and it's expensive. So when we look at actual toxicity rates right now, comparing protons versus IMRT, is it the best thing ever? Not yet. When you look at toxicity rates, you see almost twice as much GI toxicity after proton therapy as you do with standard IMRT from two separate studies that were done looking at Medicare data. One of the reasons that IMRT has gotten so better with our ability to focus the radiation and put it where we want and really shape it, we need to make sure that we are putting it in the right place. We used to think, hey, everything inside the body stays inside the body. It's not going anywhere. But nowadays, with image guidance, we've discovered that things are quite different. So here's the linear accelerator with the arms, the imaging arms on the side. And basically, image guidance has given us the ability to say, hey, we know we're putting the radiation where we want it. We don't need to use as wide margins as we used to make sure that there wasn't a fudge factor. That enables us to reduce the side effects of the radiation to the normal tissue while getting more radiation consistently to the tumor. So it's almost a win-win, essentially, because you're getting better tumor control and less side effects. And you can give higher radiation doses now. So here's the picture of the linear accelerator, the table that the patient lies on. And on a daily basis, what we do is actually, here's what our setup CT looks like, and this is for a liver tumor here. And then we can take a low-energy CT scan. And these days, I know there's concerns about excess radiation dose, and you hear about the CT scanners, but when all the modern CT scanners these days are 64-slice scanners, which basically means they have 64 cameras and beams being shot out. And so that delivers 64 times the dose of what we have here, which is actually a single source that's rotating around. And this is what's called a cone beam CT. So you can shoot 64 of these cone beam CTs and still not give the patient the same amount of radiation as a 64-slice CT scanner. And so essentially taking a CT scan on a daily basis ensures that we're targeting just the tumor and not the tissue. We have another technology that's called the Calypso system, and this is kind of a cool system. One of the downsides to the radiation and our X-ray detection, or image guidance, is that you can't image when the beam is on. It's kind of like trying to look at a photographic negative out in the sunlight. That's also something that's probably going to be lost on future generations as everyone goes digital. But essentially, these beacons are these transponders that we can implant into the body, and we implant them specifically into the prostate. We can implant them into breast tissue. We implant them into lung tumors. And what this device does is we have a panel that generates a radio frequency signal at a different part of the spectrum, so it's not interfering with the radiation spectrum. And it sends out these radio frequency signals, and it causes those beacons to resonate. And those resonate, ping back, the beacons ping back their location, and you can actually track that in 3 dimensions. So down to sub-millimeter accuracy. So we place 3 beacons into the prostate, and then have technicians set up the beam, the panel, over the patient, wherever the beacons are. And basically there's a couple different components to this. And we have the optical system to make sure that everything's aligned. But we're down to sub-millimeter accuracy with where the patient is during treatment. So while the beam is on, we found actually that the prostate moves, which you'd be surprised by. It's about the size of a walnut. But actually when you take common sense and you think about the fact that the whole time that we're all sitting here, our bladders are filling up, our bowels are moving things around, making stool, that's going to actually move things around internally. It's not like they're all reservoirs in our car where they all stay in place. So essentially the prostate actually, during the 10 to 15 minutes that a patient's on the treatment table, drifts downward because of pressure from the bladder as it's filling up. And so the Calypso system ensures that we're staying on target the entire time. And because of all these developments where we're able to focus the radiation, traditionally radiation has been delivered over 8, 9, sometimes 10 weeks. And the treatment fractions that are commonplace these days are 78 gray over 39 fractions or 81 gray over 45 fractions, and each fraction is a daily treatment. The technical improvements of our IMRT and our image guidance have allowed us to give larger doses per day, and then biologically there's been arguments that maybe it may even be more effective. So we've actually had a couple randomized trials looking at hypofractionation, where the standard fractionation of 38 fractions or 7.5 weeks was compared to 26 fractions. You're cutting off almost 2.5 weeks of treatment from our standard. And after 5.5 years, there was no difference in prostate cancer survival, toxicity, or biochemical control. And these are just the survival curves that show the difference between conventional fractionated radiation and what we call hypofractionated, or reducing the number of fractions. And there's just no difference in biochemical recurrence or in prostate cancer specific survival, no difference in toxicity here for GU toxicity, and no difference in GI toxicity. And this really has been only enabled in the last 10 years with our improvements in how we're delivering the radiation. So it's a win-win on multiple levels for patients. We're taking 25% off the treatment course to 5.5 weeks versus 8 weeks. No differences in side effects, no differences in disease control. And you know what? It's 25% cheaper because radiation is charged by the fraction. So really, it's huge development. I mean, how many times in medicine can we say, hey, we're actually doing it cheaper now? So the last area where I talk about radiation is where radiation can be used after surgery. And us radiation oncologists kind of are the cleanup crew after a prostatectomy. And in the past, whereas surgeons and radiation oncologists used to be at odds, these days we're kind of more, staring at the sunset together. So here's one of the randomized trials that was actually really pivotal in establishing radiation after surgery, SWOG 8794, whereas we knew after surgery, patients who had these three features, extracapsular extension, seminal vesicle invasion, or positive margins, failed 50% of the time. And then the question was, can you deliver radiation safely after patients had a prostatectomy? And this was a big concern because after prostatectomy, patients are struggling with incontinence, erectile dysfunction, and the last thing a surgeon wanted was someone to come in, a radiation oncologist to come in and muck it all up with their radiation on top of that. So they randomly assigned 425 men, and this study was actually paralleled the exact same study in Europe, which had 1,000 men. And both studies were published about the same time. But in essence, what they discovered was that the patients who got radiation had almost half the number of failures. There was, if they didn't get radiation in this randomized trial, 65% of the patients failed, with a median time of 3 years. And if they got radiation, only a third of them failed, with a median time of 10 years. And the time to initiation of hormone therapy was extended. 21% of the patients who had failed after surgery within 5 years versus 10% who had gotten the radiation after 5 years. And then with longer-term follow-up, they actually demonstrated a overall survival advantage of 10% and a 10% 15-year metastasis-free survival. So this is one of the biggest advances for localized prostate cancer that we've had really in the last 10 years. Some emphasis points. And the last part of our technology, just that what we can do now is also do intraoperative radiation. As our ability to shrink our devices has gotten better. This is an intrabeam device, and it can deliver radiation to a pinpoint area or a larger area like this. And basically what you do is once you cut the tumor out, you put the device in, and you can deliver radiation to just this area and minimize the exposure to all the adjacent tissues. For breast cancer, this is obviously not prostate, but a situation where you take the tumor out and you set up the treatment device, and then you deliver the radiation, and then you close up the incision, and you don't have to expose the entire breast to radiation anymore. And this basically shows you the Mobotron unit going into place here. So, in summary, with radiation, our goal has been to try to target the radiation, focus the radiation, deliver it where we want, and it's been translating into reduced toxicity and better tumor control over the last 10, 15 years. Basically furthering our goal of getting rid of the cancer while preserving quality of life. So, thank you.